So thank you, sir. So this is the last session of this Kolkata AIOS 2016. So I will be highlighting universal eye health for India way forwards. So now, so what should we plan for India when we say universal eye health? So before coming to the plan for the country, how this concept was generated? So first, you know that after Alma Ata declarations of primary health care, so the WHO has accepted this primary health care. So under this purview of primary health care, this primary eye care comes. So similarly, so WHO this universal health coverage. So under this purview, so this universal eye health, this concept was generated. So as you know that universal health coverage means that ensuring that all people have access to needed the service in terms of promotive, preventive, curative, and rehabilitative. So these are the key words in these definitions, and of sufficient quality to be effective, while also ensuring that people do not suffer. There shouldn't be any financial hardship, like a kind of say extravagance healthcare expenditure should not be very large. So the concept, the principles is more or less same. So when you narrow down to the ocular health, so it comes the universal eye health. So in this universal eye health, so we have a goal, we have a targets. So and then there are four principles. So to say is a approach principle as well as a approach. So the goal is to reduce the avoidable visual impairment as a global public health problem and accessibility to rehabilitation service to visually disabled. So this is the goal, and keeping the targets at 25% of the reductions of the visual impairment by 2019 from the baseline 2010. So this is the goal. So these are the principles. So the this is the four principles. So to achieve this goal, so we need to consider these principles: universal access to comprehensive eye care, strategies to interventions to ensure the International Human Rights Convention. This is all very important when you talk about the visual eye health, and this evidence-based practice. So when you implement some sort of service, maybe promotive, maybe preventive, maybe rehabilitative, it says that it should be evidence-based practice, not like just design a program, just implement. It's not like that. So it should be evidence-based practice. And one is policies and planning program based on this is life course theory approach. This is a kind of new terminology for us. This is LCT, life course theory approach. So in our life, across the lifespans, populations as well as individuals, there is a risk factor and the protective factor. They used to operate their interplay. So this theory says that while preparing a policy or planning, we should have a due consideration of this life course approach theory. What are the risk factors for particular disease? What are the protective factors for a particular disease? Maybe it could be environmental, it could be socio-economic, it could be so many things. So we should based on this LCT approach. And one is empowering, very important, empowering visual disabilities. So these are the three different principles. And coming to the objectives, this is objectives of course, but it is included some core strategies also to achieve the goals. First is to generate evidence based on magnitudes and cause of visual impairments, eye care services, and using it to monitor the progress. Identify the magnitudes and cause of visual impairments, and identify the priority and advocate for greater political and financial commitments. So second is integrations. Integrations of the eye health care system to the general health care systems. The last is multi-sectoral engagements. So when you say about the universal eye health, these three objectives should be considered. And to achieve these three objectives, now coming to the strategies, you can say strategies. So we should consider the human resource, coverage universal eye health. So human resource is one very important components to achieve the universal eye health. One is the infrastructures and the healthcare finance and the service delivery models. So we will discuss for India, for our country. So now you see when you say eye health in India, Now I'm coming to the Indian context. So in India, we have a national health missions, we have a urban, we have rural. National urban health missions and the national rural health missions. So this program documents, there's not much about the eye health. Since we have a separate vertical programs, national program for the control of blindness. Despite of this document, so we have the separate vertical programs. It's very strong, you can say. So national program for control of blindness. So to me, I think like when we say national program for control of blindness, so we need to consider about universal eye health. So it should be like a national program for control of visual impairment. Maybe. So NPCV little bit about, it was first, say National Trauma Control Program in 1963. It was launched in 1976 and centrally, 100% centrally sponsored and decentralized at district levels. Now to the current scenario in India. So the prevalence of blindness in 1970s is around 1.4% across the age groups. And in 2001 and 2, 1.1, and 2006 and 7, 1%. Now 2016-18 RAP survey is undergoing, so we'll be having reports at the end of the 2018-19. So this is the prevalence of blindness. When coming to the visual impairment, so approximately 3 times of the above statistics is a visual impairments. When you say blindness and visual impairment. So say for example, currently say around 3.4%. So 3% of this, approximately, it is approximately. So 3.4%, this is prevalence of visual impairments. So the 25% of reduction by 2019 from the baseline means it should come around 2.5%. So our target is to reduce 1% of the visual impairment across the country. So now coming to the human resource to achieve these targets. So this is the current, you can say current scenario, because we don't have any other study on the situation analysis of human resource after 2004 published. So this is the private NGO and the public sectors. So what we need to do is we need to strengthen these public sectors. We need to strengthen in terms of as a human resource. So right from the primary levels up to the secondary, tertiary. And now coming to the healthcare model. This is general healthcare models, not the eye healthcare. So we have the tertiary care, secondary and primary. At the primary level, I would like to focus because we are talking about the universal eye health. So at the primary levels, we have this much sub-center in the primary health center. So this is around 1,72,000. So primary health center is around 24,000. So we need, so coming to integration. So this is eye care models, pyramid model. So we have enough of this center of excellence. This is targets, training center, this is target, service center, this is targets. But this vision center, which is supposed to be serve that 50,000 for one vision center. So in India, for the general health care, so one primary health center cater 30,000 population. So here vision center supposed to cover 50,000 population. So approximately 2 PHC, 2 vision primary health center can be covered by the one vision center. So out of this 2, one can be nominated, develop a designated vision center. So so this is, I just would like to give some emphasis that why this primary health care is very important. This is a health policy journals. So it has been already proved that number of hospital beds per 1,000 population does not appear to have a significant correlation with any of the health indicators. So this primary health care seems to play the important role to improve the countrywide health system, health indicator. So this is published in 2010, the health policy journal. Now coming to distribution of eye care facilities and infrastructure. This is a distributions, private, governments and NGO. See, so now public-private partnership. So here to strengthen this eye care facilities and infrastructures, we need to strengthen, we need to upgrade these PPP models. And once you thought, say, irrespective of the sectors, maybe private, maybe government, maybe NGO. So maybe like we should plan some kind of mandatory for a community-based eye care service, maybe private, maybe governments, because so there we have so many designated eye hospital, medical college, multi-specialty hospitals. Each and every hospital, if they have some kind of policy that you should have a community-based eye care service in the model of vision center. So this can be one, in the planning. Coming to the healthcare expenditure in India. So this is another very important. So in India, so individual households is, when you talk about the healthcare finance expenditure, so it's around 72%. So what do we need to do is health insurance. So because in India, you know that below poverty lines, economically weaker section society is a huge proportions. So health insurance, we need to work on it as well. And the healthcare finance, so government has to increase the healthcare funding. When you say thinking of covering this universal eye health, and the external funding and some philanthropies, for example, say Bill and Melinda Gates foundations, like that. And this is a message I would like to just give to all you, that there's two pillars. This is eye care service. There's a hospital based and community based. In hospital based, we have the center of excellence. We have enough of service center. We have enough of training center. And this is community based. There's thin line this current scenario. It should be both equal. दोनों बराबर होना चाहिए. दोनों बराबर हो के हमारा जो target है, it should be, maybe it should be achieved. Thank you. This is the last slide.